You are addressing an extremely important issue, one of pregnancy in cancer, what you do about the pregnancy, what you do about the treatment of the patient, for instance. First of all, you've done a couple of studies, one on what happens to the fetus when the mother had chemotherapy and also radiotherapy. Give me the data on those trials, please.
We have two trials that we provided interim data. First is on the antenatal exposure to chemotherapy, where we have a case control study where we compared 38 children who were antenatally exposed to chemotherapy with 38 children from the normal population. And the mean age of the age was between 18 months and 42 months. And it appears that actually the outcome, the mental developmental index is actually the same for study children and controls. We did see that the number of chemotherapy cycles did not influence the outcome, but we did see that antenatal birth resulted in a worse outcome, both in the group exposed to chemotherapy and in the controls. So from that study it appears that premature birth is a problem, but chemotherapy is not a problem during pregnancy.
Right, so if the mother has chemotherapy while she has the baby in utero, it's not a hazard to the baby?
There's no hazard as far as we have the data on these 38 children. You cannot differentiate a child who has been exposed to chemotherapy from another child.
Now you've got another study on the use of radiotherapy. What happened there?
It's a similar study, or the children had basically the same examinations done, but children were also older. So we had 16 children with a median age of 6 years, and we had 10 adults of a median age of 33 years. And we have looked into the attention to the behavior and to the general health, and we see that the antenatal exposure to radiotherapy does not impair their outcome.
Now, what then is the clinical bottom line to this issue of pre-birth exposure to radiation or chemotherapy?
The clinical message for chemotherapy is that after the first trimester of chemotherapy, chemotherapy can be administered to pregnant women, and that will result in less terminations, adequate maternal treatment, and avoidance of prematurity. For radiotherapy, it's the reverse. Radiotherapy, when the pregnancy is far advanced, then the developing fetus comes closer too close to the radiation field. So in the third trimester, radiotherapy is not possible, but radiotherapy is possible of upper parts of the body during the first and the second trimester of pregnancy.
Right. Now, you're also building up area in a different you're building up expertise in a different area, and that is on pregnancy and the use of sentinel node biopsy, because this has been avoided in pregnancy, hasn't it? But you're now challenging this.
We are challenging this. We not only focus on fetal safety, but we also look into maternal safety. How safe is a standard procedure which is standard in non-pregnant women? How safe is this in pregnant women? And there we show in 97 women who were pregnant with breast cancer during pregnancy, in whom a sentinel lymph node has been done, we only saw one recurrence, isolated recurrence in axilla. So we believe that this procedure, which is standard in the non-pregnant population, can also be used from a maternal perspective in pregnant women.
So despite the present guidelines, you're reassuring that these women who are pregnant don't have to have axillary dissection necessarily?
Definitely. We can use the same criteria as a non-pregnant to decide whether or not to do a full axillary dissection.
You've also done research on avoiding pregnancy during cancer treatments, and remarkably, I heard from your talk here at ESMO that there has been a small incidence of pregnancy in patients being treated. What are your findings?
We saw that in cancer patients who are young, that 3% of our population, that were 29 women, became pregnant where pregnancy was not the purpose. So despite chemotherapy, hormonal treatment, Herceptin or radiotherapy, there was an unplanned pregnancy. And the main message for clinicians is that in young women, when they get cancer treatment, that contraception should be discussed. And if it's not discussed by the medical oncologist, he should refer the patient to a gynae or to a general practitioner.
And finally, could I ask you about your work in cervical cancer, the Prognosis for mothers? What have you been doing there?
We, in the framework of the International Network on Cancer, Infertility and Pregnancy, we have a registry, and we're there looked into cervical cancer cases that have been diagnosed and treatment during pregnancy. So, and there we have done a case control study with cancer patients who are not pregnant, and it appears that the prognosis of cervical cancer during pregnancy is comparable to the prognosis in non-pregnant women. So even in cervical cancer, which is the most difficult situation to handle because the pregnant organ itself is involved, their cancer treatment during pregnancy is possible without compromising the maternal prognosis.
Now, up to now, doctors have been very cautious about the whole issue of pregnancy and cancer treatment. What are the simple statements that you might like to make at this point? You've got quite a lot of data in, you'd like to get more, but how would you wrap it up at this point?
That despite the fact that it's a complex situation, that we should not panic, we should take time for a second opinion, time to go to a center where people have sufficient expertise to handle this, and to appropriately stage the patient and treat the patient in an interdisciplinary setting where surgery, chemotherapy and radiotherapy can be considered. So we do believe that that we can come very close to standard treatment, what we use in non-pregnant women, that we can also use this in pregnant women.
But there is quite a lot of reassurance here. What's your bottom line message?
That also pregnant cancer patients deserve a treatment which is as good as possible and as close as possible to non-pregnant women.